Morning, guys. Morning. We're live. Morning. We're live. Thank you, Darine. We're live on the YouTube. Welcome to season 2 of our Tuesday mornings webinars. For us, it's a great honor that you are there on that side of the screen to witness season 2. Season 1 was about lead review and treatment plan seminar. We had the opportunity to listen one of the finest members of the YAD Lisbon and some invited guests. We had João, we had Helena, we had Hagata, we had Pedro, we had Mariana, we had João, and a lot of cool seminars. But this time, we want you to be involved. So this second series is about what would you do? And we posted on Instagram a clinical situation. I will be, the pleasure to open this season. So it's a case about implant dentistry. So it doesn't mean that the next week is about implant dentistry. Actually, next week is about prosthodontics. So, you have all the spectrum of dentistry presenting in this seminar. So what we show you and posted on Instagram was this clinical situation. And this was a patient that was referred to us with a problem on number 13, like we posted on the Instagram. As you can see here, the patient already was wearing orthodontic. She was doing clear aligners. And obviously, one of the aspects that she didn't like is that she's a young girl with 31, 32 years old that doesn't like the smile. Okay? And besides this, number 13 has been treated for the last 10 years. Endodontic treatment, composite restoration, and the tooth was always hurting, wobbling, and she passed the last 10 years going to the dentist to treat these tooth. So she decided to go and find another solution for the case. So she was referred from the general dentist to us. So at the first appointment when we did the CBCT, this was the second clinical picture that we showed to you, we saw that, number 13 had a huge problem, okay? Not only it was hurting, pain, aesthetically unpleasant, but she also had a problem on the roots, a periapical lesion, probably residual from all the surgeries that she's been intervening in this situation in here. And you see there's not much tooth left in this situation here. So the question was, what would you do? And so we posted 3 clinical scenarios for you. The first one was, well, should we keep the tooth? Should we keep the tooth of this patient and, do the other treatments and just keep the tooth? And 30% of you voted, yes, let's keep the tooth. It's, for me, it's a little bit surprising. 30% keep the tooth, but, it's your vote. Then we move, okay, if the tooth is coming out, if you're going to extract the tooth, what should we do next? And if you go for an implant-supported rehabilitation, 2 situations appear. Should we do an immediate implant, meaning that we should extract the tooth and then place the implant? Or should we go for a more conservative way, extracting the tooth, wait, and then do a delayed implant placement? For me, is also here the discussion. That's why you see that 41% of you voted immediate, but also 30% voted delay. So there's kind of, some of you voted, yes, we go this way, but I'm not so sure. And some of you voted this way, but also not very convincing. And it's actually a very difficult, clinical situation to judge. So we also had the same questions for what we had to combine all the expertise from another fields to come out with a treatment plan, with a correct treatment plan. So, here is our clinical situation. So the first thing that you have to evaluate is an aesthetic problem. We have an aesthetic problem here. If you're from the prosthodontic department, this case goes to the prosthodontic department. Immediately when you see, the line of the zenit of these central incisors, you see there's a big discrepancy over the lateral incisor. Although this looks like a canine, this is a lateral incisor, okay? So if you went for your aesthetic classes in your university, you know that probably the lateral incisor is a little bit lower than your central incisor, okay? Okay, are you seeing me live?
Yes.
I'm here.
Yes, yes.
I'm here. I'm André, by the way, okay? since the YouTube? Yes. All right. So if you're going to your aesthetic classes, your prosthodontic classic literature, you know that the lateral incisors should be, 0.5 millimeter to 1 millimeter, coronal to the central incisor, right? The aesthetic department is here. Yes, so yes, say yes, please. Say yes, please. Say yes, please. Say it. But what we see here is that it is not, okay? Actually, it's not only 1 millimeter below, but it's actually almost 3 or 4 millimeters, apical to this zenit. So we have an aesthetic deficiency, a soft tissue deficiency on this area that is very clear, and that's why she doesn't like the smile, okay? There are other problems that there are here, but this is the main one. So let's go to the fact. This patient is referred to us because she's undergone on the last 10 years, to try to treat these tooth. She feels ugly, she's not confident smiling, she has a problem of social smiling because she has a moderate smile line. It means when someone tells a joke, she does like this. She doesn't do like this because, the lateral incisor has a problem, okay? So she wants to close this chapter. And the question that we also did, should we keep the tooth? Yeah, let's try to keep the tooth. So we had to evolve, other disciplines in order to make that decision. It's not a decision of the oral surgeon. It's not a decision of the periodontist or the prosthodontist or the orthodontist. It's a combined decision, that the patient is also involved in this decision. So the first thing that we should do is that, let's redo the endo. Is it predictable? Yeah, I mean, we can redo the endo. I mean, there's not a problem, but there's not much tooth left. I mean, if you're going for the survival rates of only the endodontic, yeah, I mean, it's 90%, but you just don't have to have that tunnel vision that you only look to the problem of endodontic. Because if the endo is okay, how do you address to the soft tissue recession that she has? Are you going to make multiple soft tissue coverage on the tooth that is wobbling? You're not going to do that because, it's a lot of surgeries to go on a tooth that is already almost gone. So this is, for us, a big problem. But imagine if you address the endodontics and address the perio, so how are you going to restore these tooth? Okay, that is also, from the prosthodontic side, a very tricky tooth to restore. A crown with these crown to root ratios, yes. Is it predictable? Not a chance. And by the way, the patient came here because on the last 13 to 15 years, the endodontic and the crown and the fixed prosthodontics was the solution. But now she wants to move to another level. And so, by doing all of this and making the patient go through multiple disciplines, is it predictable? Of course not. It is not predictable. I mean, you can do it, but it's for sure not predictable. So, you have to look always to the story of the patient. It is very important that you don't see here only the tooth, but you see this as an holistic. Holistic meaning that you have a global treatment plan for this patient. The problem is number 12, but it's also occlusion, is also an aesthetic problem that we have to address. So, would it solve the problem to the patient if you go to this chart here? And we all unanimously said no. It will not solve the patient's problem. So, at this time, we are not thinking about endo versus implant, okay? Because it's two different therapies, like we stated in the other webinar. Endodontic tries to save a tooth that is in a mouth. Implant dentistry is to restore a missing space. So it's never about endodontic or implant dentistry. It's about endodontic or extraction, because there are multiple ways to restore a missing space. So in this case, extraction was above the table. And here is what it comes to an evidence-based approach, because I hear all the times that, literature doesn't say this, literature doesn't say that. Yes, that's a big important fact, but where you're in the clinical arena, there are two factors that make you do an evidence-based practice. Is not only the evidence and the research that you have, but you have to combine this with your clinical expertise. What do you do best? What it works on your hands? And then having these two, align, you have to make the patient be involved in the decision. And the ultimate goal is that you inform and the patient has to decide the best treatment for them. This is the evidence-based practice, which is very important. So, in order to achieve, the best clinical practice, you have to have the best clinical team, okay? No, it's not your joke, because on the other webinar, we were very, opera, and all of this is so beautiful. This is always, such an idyllic situation. But this time, it's not about the opera. Now we have to go into the action. No more funny stuff, no more, idyllic. Now, in these cases are the ones that you have to grab it. So there's no more a story of the good guy. Now you have to be very aggressive and know in the clinical arena what you can do. And so, we ask the expertise of the two best practitioners in the world in the field of orthodontics and the field of prosthodontics. Well, actually, it's prosthodontics. He goes out in the disco, he does plays tennis, and me, the Luciano Pavarotti, it's Christmas, I'm sorry, I need to. But so, we need to go. And, this is the holistic version of the treatment plan. She was doing, an orthodontic treatment, then Elena can go in detail in another course, but basically the treatment was not having much effect. I don't understand nothing about attachments, although I'm wearing orthodontics. This is my resolution of the new year. You see here that it was crossbite here, the tooth was rotated. So in order for this case to arrive to João, in proper conditions for the crown and veneer, to not have too much, abrasion of the enamel and so on, Elena has to place the teeth in the proper position, not only, on the mechanical aspect, but also preparing the case for the veneers that João was going to make. So the first part was orthodontics. Elena didn't do this first part of orthodontics. She only entered afterwards, as I'm going to show on the beautiful clinical pictures that she has. So, they try to move those tooth. Okay. So, our decision was to extract the tooth, okay? So what should we do after the extraction? And the question is that, are you going to place a removable prosthesis? No, of course not. I mean, this young lady doesn't look and doesn't need for a removable prosthesis, but it's an option, a rehabilitated option that for this patient doesn't work, but maybe for other patient it would work, okay? So it's something that we have to put on the table. So, but this case, clearly, it's not an option. The fixed prosthodontics, like a Maryland style of bridge, we had here a lot of speakers from Geneva University. They publish a lot about the situation, But I agree in some cases where you don't have space to place dental implants. But in this case, it was a pretty favorable case. We have a lot of bone available. So we talked to the patient about this situation, and it was something that she was trying to avoid, having a tooth that is holding through the other when another option of a dental implant was in the table. So, our decision was to place a dental implant, okay? And when we decided to place a dental implant, obviously for me, it's one of the best days because let's place a dental implant. So I put the emoji because when I took this photo, I said, this reminds me of someone. I don't know what, but then I realized it's the emoji that reminds it, okay? So we had to go for a dental implant. So now the decision comes, should we place this implant immediately after extraction, or should we do a delayed implant placement? And this was the discussion. Half of you voted immediately, half of you voted delayed. Well, I'm a big fan of immediacy, as you know. I've been talking a lot immediate implants for the last 2 years with Straumann and all these immediacy concepts, the BLX, the TLX, and everything. You know me because of this. But there are rules to do immediacy. It's not just, you have an implant that's, let's do immediacy in everyone. there are rules, there are biological rules that you have to follow, because if you don't follow them, you will be in jeopardy and the clinical case finish awful. So the first thing that you have to ask yourself is, do I have buccal bone available? Do I have the buccal bone available? Yes, I have the buccal bone available. You see here, you see here very clear that you have the buccal bone available. So for me, this is a yes. Oh, there's bone available. Because if this was a type 2 socket with no buccal bone, or a type 3 with a soft tissue collapse, for sure, almost all of you would say, let's go delayed. But because there's a buccal bone here, 30% of you said immediate. And you're right. The second thing that you have to ask is there apical bone to anchor your implant, to have primary stability? And you have seen here that you have bone. So you have bone to anchor a dental implant. Well, sometimes you're under the sinus, sometimes you're in the mental foramen or the inferior alveolar nerve, and you don't have, bone to anchor the implant, so you have to go delayed. But this time here, you have bone available, so you can place an immediate implant here. So it's an okay. Do we have an acute infection? No, we don't have an acute infection. We have a chronic infection here, but the literature clearly states as if you remove everything, then it's a green light. So even the acute infection, it's not an acute infection, so that's why it's a yes, so go. So everything would seem to point that, go for an immediate implant, except for one fact. That is a soft tissue recession that we have here. We have a soft tissue deficiency here. That means it's a big, caution to do this, because sometimes it would work okay, and the tissue more or less comes down, but sometimes it does not, okay? And there is no worse day for you that after 3 months of your immediate implant, the patient comes with an osseointegrated implant and a soft tissue deficiency on that implant. It means that you're gonna start to sweat. And everything is very beautiful if you do immediacy. Hey, we do immediate implants every day. We have a very famous disco around the corner where the next day everybody comes with a central incisor lost. So this is one of the cases. She broke 21. We did an immediate implant. Yes, we did an immediate implant. It had all of these characteristics plus not a soft tissue recession. Do you know where is the implant? No. These are, the cases where you should go with immediate implants. Another case, the lateral incisors. Everything is here. There's no soft tissue deficiency. You do the immediate implants. 3 months later, the prosthodontic finishes the job. And you see here the zenits of these tools, work of Dr. João. You see the zenit. They're okay. This is immediate implants. There's no soft tissue deficiency. There was no soft tissue graft, there was no bone regeneration, only to follow the principles of immediate implants. And you have good zenits. And we can, be here all day for me to show you immediate implants that were successful. But there's the dark side, okay? There's the dark side of the immediate implants. And these ones, normally people don't show you on Instagram and don't talk about. Sometimes you do immediate implants with soft tissue recessions, and look how the case ended. It seems the first picture of our case, it ended up like this. So now go to solve this soft tissue recession with an osseointegrated implant. It's a nightmare. It's a nightmare. Good luck with this case. Another 3 or 4 surgeries to the patient. I did this case long time ago. Look at the discrepancy here. This is immediate implant. Wow, go to the immediate implant. There was a soft tissue recession before, the bone was okay, the implant took over, but there's now a soft tissue recession on this case, okay? Cases like this, immediate implant. What happened here? There was a soft tissue defect in the beginning. And so these are the cases where you should be very careful with immediate implants. So after 25 years, we learned the hard way, okay? We learned the hard way. We learned the hard way. So it is obviously that for me, in this case, it is not for sure an immediate implant placement because of the soft tissue recession. And why? I cannot predictably say that after osseointegration, I will have a soft tissue profile just on the level that I want. So this is not immediate for me. So the question is that, is this an early placement? Wait, extract the tooth, wait 2 months and do the implant placement? or it's a delayed implant placement, where you wait 6 months and then you place the implant, okay? So either way, it's not an implant, it's not an immediate implant for me, okay? So what we decided was, you can go extract the tooth, wait 8 weeks for soft tissue closure, do your guided bone regeneration and your implant in one shot, and then wait, go for the provisional or final. Or you do a delayed implant placement. It means that you extract the tooth and then you wait 6 months, you do all the treatments, and then place the implant after 6 months. This was the technique that I follow, because this technique has an advantage. The socket preservation, if this, it's not, my favorite technique, but in cases like this where I want soft tissue to fall down, this may be a good option, because the lateral incisor, sometimes heal with the proper dimensions after the 6 months, and you don't have to do major grafting afterwards, because you have a lot of bone in this situation. So for the patient means, a very pleasant visit to the dentist. That's what we want, because she has been doing this for the last 10 years. So we did a socket preservation type of technique. We extract the tooth, and then we did an ice cream cone technique, described by Nick Elland and Dennis Tarnow. And it's not one of the most photogenic, images. You have the membrane there, you have a collagen membrane exposed. But it's a very effective therapy in preserving not all the dimensions, but some of the dimensions that could even prevent you to go and do guided bone regeneration in a second phase. So here, as the provisional, João did a Maryland bridge, for the provisional. And Elena, started to do the alignment with this provisional restoration. So now you see, where your soft tissue is, okay? You see the membrane, and you see the bone that is up there. This was on the day of the surgery. We extract the tooth, and then we grafted the area in the socket preservation. So the objective of this technique is to let it fall down the tissue to a more coronal space, okay? Because the bone, you have the bone. If I showed even to Pedro from the oral hygiene, can you place an implant here? Yeah, I can't place an implant there. I mean, it's a very big chunk of bone. So the problem was not this. So after 2 months, it's a completely different situation, okay? Even for the patient, without nothing, she can easily understand that now she has tissue on this area here, okay? So only by extracting and make a simple socket preservation technique, you allow the soft tissue to come to a more coronal space, the natural healing could flow. Here is the difference before and after, only by doing the extraction and the soft tissue, okay? So now I'm in the position, so now I go to the appointments and say, okay. See? I told you that, okay, so this, because you don't have nothing there, you don't have an osseointegrated implant, the coronal tissue is there, so everything is falling down. So after 6 months, you have here, the CBCT of what was left. This follows, the classical patterns, that Araújo talked about, the extraction socket, follow the articles from Caneva, follow the articles from all the Gothenburg literature that talks about, what is going to happen to the extraction socket. We lose the buccal bone, but then the socket preservation, the xenograft that is there, holds the bone, and so we have here a situation of very stable bone. So what we do next, okay, it's not over, okay? You said, I'm going to place an implant. Yes, but which type of implant do you going to place here? This implant has to last, she has 30, this implant lasts 40 years. So what are you going to do here? And the first thing that you have to know is there are different tissues around this area. There's a trabecular bone, there's the cortical bone, and there's the regenerated bone. So the vital bone in each one of these are totally different. So this is xenograft with probably 70% of connective tissue here. So there will be not much osseointegration here. It will be, like a fibrous integration with xenograft particles over here. So in this case, we go for an hybrid type of implant, meaning that we have rough surface in the implant for osseointegration, those 75% of bone to implant contact. But this area here, you have a polished color, for the high amount of the soft tissue. And this is very important when you do this type of techniques, that you understand that there's an implant, there's a correct implant for each correct situation here. And we're going to place an intermediate abutment, and then we're going to place the crown. So everything is set for soft tissue recontouring here of this area. And so here you have the implant placement. You can see clearly here the xenograft. This is not all bone of the same quality. You have regenerated bone and you have native bone. On the part that you have regenerated bone, you have a polished color. It is very important for the long-term maintenance of this case. And so we place the implant and João placed the crown. And so my work is done. My work is to deliver the case in the proper soft tissue contours to the prosto department. The orthodontic, of course, picks up the case and does a beautiful job. Thank you. Once again, thank you. And putting, the biomechanic in the correct spot. See, there was, it's a cross bite. There's no cross bite anymore. Nice work. And everything, this state was rotated, not rotated anymore. And you see, that the soft tissue is still maturing on the implant while the orthodontics is doing the final veneers. And then we send it to João. João will get into details if you want. Just call him, ask him about the veneers, about the limits and all of this stuff. But the idea is that now he has a pretty comfortable working zenit to finish the case. You see the difference, where we started, and by only doing a socket preservation technique, we get the tissues to come down. There was no soft tissue grafting, no soft tissue manipulation, so there was not palatal harvesting, tuberosity harvesting. There was nothing. We just work with the biology. You see here? Now if you draw the line, you could be on the aesthetic books that you have there. I mean, you have the lateral incisor, 1 millimeter coronal of this line from the canine to the central incisor, okay? So for João now is just finishing the case, okay, and let the patient, smile again. So this is a work of the prosthodontist that is in the room. Nice round of applause for the prosthodontist, okay? Nice round of applause for the prosthodontist.
And the lab.
And so the lines now are pretty even, as you can see here. And that was our treatment plan for this patient. So it means that there's no correct answer. The answer that the clinical situation that we end up doing was a delayed implant placement of this implant. So what is the take-home message? Okay, there are a lot of ways to get to Rome. Okay, Rome is just around the corner. You can go with one technique, you can go with other technique. But what is most important is the correct treatment plan, case selection, okay? Case selection is very important, and obviously, a team that allows for this patient that was referred to us, come out to our office and can smile again with a beautiful smile, that restored the social balance that she needed. And that is only due to the teamwork, not only the doctors, but also our international advanced dentistry team, okay? Thank you very much, and do not miss next week, João. Thank you.